This session is all about what's special about St George's. Now, things we do well, we probably don't need to tell you about, you'll find out about them anyway. But there are things that we do a little bit differently, and some things that frankly go wrong that we need to let you know about so that you can be wise before coming into that situation for yourselves. So this is what we'll be looking at in this section. First of all, how we run our emergency department, some things we've learned around delirium and dementia that have disadvantaged patients and we think you should know about so you don't make the same errors. There's some things about consent and personal identification and preparing people properly for surgery. Physician associates are special things that we have at St George's that you may not have encountered before, so we've got a few minutes about that. End-of-life care, a bit about the library, and last but perhaps most relevantly, what goes wrong. So this is again learning from our own serious incidents and passing on the information to you. So let's start at the top. Now we've got a very, very busy emergency department. 110,000 patients tend to turn up every year, and it goes up by around 10% per year. The emergency department is a very hot spot within the hospital and can frequently get overwhelmed by patients. One of the challenges we have is actually moving patients out of the emergency department and onto the wards quickly. And again, one of the challenges around that is making sure that they're seen in a timely manner and then admitted to the wards. And for that reason, we've developed internal professional standards for use by medical teams for the emergency department. So please don't switch off if you're an emergency department doctor, because this stuff is designed particularly for you. These are the standards, and they're written everywhere, all over medical wards and in the emergency department. First of all, emergency department referrals are made to the registrar in the admitting team and not to a more junior member or to the consultant. This means that they're in the proper place to triage them appropriately. Once you've had a patient referred to you, we expect to see a written plan for that patient within 60 minutes in the notes. You can't refuse if you've been referred to a patient or conditions like it needs to have a CT scan first, anything like that. This just dumps work back on the emergency department and makes it impossible for them to manage their own workload. Now, we appreciate that from time to time there will be patients inappropriately referred, and there has to be some problem in every system. This is probably the problem with this system, which we look at regularly to make sure that this isn't becoming a problem. If you're referred to and you think a different specialty is the one, do not dump this back on the emergency department. You will be making the referral to another specialty. Once you have admitted a patient, there may be some doubt over the clinical ownership, and this is actually done by consultant discussion if there's any doubt. Sometimes emergency department gets patients directly sent from the outpatient department. This is again an inappropriate abuse of the emergency department and only for emergency treatment, therefore. The GP referrals, if you're a GP and you're referring in, sometimes they just phone up the emergency department. In that case, the emergency department must see the patient. But if it actually has been referred to the specialty, please don't ask the emergency department to see the patient first. It just adds to their workload. Now, we've got some sensible things down the bottom there on the right about just not admitting, just to avoid breaching. We actually try and do the right thing for the patient, and we sort out the numbers at a later date. So don't put a patient in a ward bed just to avoid a breach. Last thing is, nurses are also very skilled and competent people. They can organise beds and support them too. So we hope these things you'll be able to find easy to stick to, and will make a big difference to the flow of patients in and out of the emergency department. Okay, this is a fairly scattergun approach. The next area we're going to be looking at is around confusion, delirium and dementia. As I'm sure you're all aware, many patients are admitted with these problems to the hospital, and confusion is a prominent symptom for many situations. These are the key questions, though, that you need to be considering. Perhaps before going into these, we ought to note that delirium is an incredibly important thing to find out. It's a correctable change in mental function. However, if you don't correct it, it may become permanent and there may be a drop in overall function, and so it could be very critical in the patient's long-term outcome. So your first question is this acute, chronic, or acute on chronic? And this gives you a huge clue as to whether the confusion is caused by dementia or delirium. We've got various questionnaires that are easy to obtain online or around the departments to find out how bad that confusion is. And then the next question is, are they delirious? And this is a key thing to find out because it tells you so much about the etiology. More about that in a moment. Your last sort of sub-question is around capacity, because it's very important to find out if a patient is able to consent for themselves and able to understand what's going on. And if they're not, of course, then you rapidly need to get other ways of finding a decision maker on behalf of the patient. Now, fortunately, we're aware of this problem and there's lots of help to hand. We've got a senior registrar, liaison psychiatry, and the neurology SPR is also very helpful. And you can find those numbers anywhere on a phone book. We've also got a CNS in dementia who will be very, very keen to come and help, and a consultant geriatrician. There's several consultant geriatricians, but this one decided to give her name. Now, delirium, you could say it's exactly the same as an acute confusional state, and that definition is very helpful. A disturbance of mental function with an acute onset for hours or days and a fluctuating cause. Now, this can be caused by a variety of different things, but particularly medical problems and medication can lead to this. But it's very important to identify the cause so that the patient stands the best chance of recovery. The key thing is, though, that you work out what to do. Avoid the risk factors, high-risk medications, and there's a list there that you can look at. Pain can also lead to delirium, so managing the pain properly is a good idea. But general things that improve the function of the brain, like ensuring adequate oxygen, fluid, electrolytes, preventing infection, dealing with infection, these are the ways to avoid delirium. Invasive lines are a particularly important, avoidable cause of delirium, and we can therefore avoid them wherever possible. In terms of determining the cause, a proper history, it's just basic medicine really, proper history, but particularly focusing on the past medical history and the drug history is important. And then you'll examine and thoroughly investigate. But particular things to look for and that you might not expect is a detailed examination of the drug chart and also thinking about alcohol or drug withdrawal. Now, dementia is quite different, of course. You get an insidious onset, it's progressive and irreversible, and very, very common amongst our medical and surgical admissions. We've got a range of causes there on the right-hand side, and it can affect many, many things in conscious functioning. You ought to know that many patients who have established dementia will have what's called a hospital passport, and this is very helpful to let you know more about their background and their medication. Now, one of the areas which gets particularly interesting is around challenging behaviour. And by challenging behaviour, we mean sort of noisy, shouting, inappropriate behaviour, much more common, of course, at night, and particularly a problem when patients who have delirium or dementia become confused and frightened in an alien environment like the hospital. And so quite frequently doctors will start reaching for the prescription for some sedation. This is not a great idea except in certain situations. And the situation most important where you can sedate someone is if they're a risk to themselves and other means have not worked. We have a trust protocol, of course, on managing acutely agitated patients, and it's worthwhile reviewing that if this is a common situation for you. The most important situation to avoid is when you have an agitated patient who has a medical cause for it, and you just basically sedate away the symptoms, but the medical problem carries on. Particular causes that seem to come back and turn into SIs are subdural hemorrhage and brain infection. Now, if you have to sedate someone, review that daily. Do not stick it on the regular side, because this will just cause further problems down the line. Okay, moving on for our scattergun approach. Just one slide really about the library. We have a very supportive and helpful library, and they're very keen to have you welcomed in as new doctors. They're good at searches. They've got some extensive paper and electronic journals waiting for your interest, and of course you can use an Open Athens account as well. So they're down at the Round Robin, and so maybe you'll see them there, but also they can be accessed online, and there's the web address. End-of-life care is another area that we've discovered that we're not particularly good at St George's, but probably every hospital has the same problem. The key messages I've tried to summarise here. First of all, you need to identify for a particular patient that death might be a likely outcome, and then you move into an end-of-life scenario and start thinking very specifically about that. Discussing with relevant patients about DNA CPR is very important. There's really nothing worse than trying to resuscitate someone who didn't want to be resuscitated, but nobody got around to actually having the conversation. So it's very important that you actually have a frank and open discussion about this with your patients as soon as it's clear what's going to be going on. There's a big shift which we often appreciate in medicine between actually going for active treatment, where cure is the goal, towards symptom control. But of course, don't forget that you can do both things at the same time where appropriate. Documentation, particularly in the current era of handovers and shift systems, is particularly important. So make sure that any discussions you have are properly and clearly documented in the notes. And if you're embarking on a DNA CPR route, make sure the appropriate form is filled out. Now, St George's has an end-of-life team, and they're very, very happy to be involved in any situation in this kind of realm. St George's is very lucky to have a lot of physician associates. Many of you will have worked with these before. Of course, they're medical professionals, but they're not doctors. They have a 2-year training following a science degree. So they kind of know their background science, and they've got a fair understanding of medical processes. The fabulous thing about them is they stick around for a long time. So instead of you guys who rotate every 6 months or a year, they're often in the same post for a number of years and really get to know how to manage that sort of a patient. So that's their big advantage. At the moment, their big disadvantage is that they can't prescribe, and there's some limitations around ordering of x-rays as well. This will probably change in the next few years, but that's where we are at the moment. They can be very, very useful in patient assessment, arranging things such as investigations, doing procedures, and generally helping on the ward. And the idea is that they work in teams under the supervision of a doctor. We'll see more and more of those as the workforce changes over the next few years. One thing you'll probably note is that they're very enthusiastic and very approachable. So if you don't know what they're meant to be doing, ask them and they'll probably put you right. My general experience is they seem to be much better than anyone expects. Now, never events. Never events is a particularly worrying thing because it sounds like they should never happen. And this is some national data looking at the never events that might occur across the NHS. And as you can see, there's an awful lot of things that should never happen. Unfortunately, they do, and they happen at St George's too. So just quickly whizzing through that list there, we see that virtually all of them are related to surgery in some way or another. There's also nasogastric tubes, which is there, and we've already talked this morning about some blood transfusion, and there's some other very oxygen and gas specific things which relate to anaesthesia. So wrong site surgery is right at the top of the list, and it's an absolute disaster when this occurs. You may be interested to know, for instance, that we have had no wrong site surgery in the last year. However, we have 3 CTs that were done on the wrong patient, which is quite alarming, really. And it's all down to procedure. And as I mentioned in one of the other talks, the procedures and protocols are there to protect patients, and they're there to protect you. And when we look at why these things have happened, almost inevitably it's because the wrong procedure was followed, or the right procedure was not followed. So wrong site surgery is just an absolute disaster when it occurs. And when you actually analyse the data, and I've got some there on the right-hand side, you can see mostly it's down to procedure, as I said, or communication, but lots of other factors may be important as well. Adhere to the procedure and it won't happen. Key to it is proper labelling, and this should be done with a conscious patient well before the surgery, and documented on the patient as well, as you can so clearly see described. Now, this X-ray is a very interesting one. If you look at it carefully, you will notice one fairly major problem with that. This X-ray was actually done on a patient who had some surgery for a broken ankle, and after the surgery he didn't really wake up very well, so he went to ITU, and in the ITU he had a deteriorating chest. At some point he coughed, and a number of his tubes were resited, including his nasogastric tube. Sometime later, they noticed his chest was continuing to deteriorate, and this X-ray was taken, and they noticed his worsening chest. This carried on for another couple of days before somebody noticed that the nasogastric tube was not in the right position, and had actually gone down the right main bronchus. So this is a misplaced nasogastric tube. There's very clear guidance on placing nasogastric tubes, but be particularly aware of the unconscious patient or the patient with a reduced GCS, as they may not have a normal cough reflex. In this patient, the correct procedure of taking an X-ray, if there was any doubt at all, was followed. However, nobody looked at it thinking, I wonder if the nasogastric tube is in the right place. They were more interested in the chest X-ray, appearance of the lungs, and in the position of the ET tube. This little set here is a very interesting set. So this is a set that was set up for a registrar who was about to put a line in, and in a trauma setting, and the patient had no line. So the patient, the registrar took the cannula, which you can see in the middle of the picture, sighted the cannula, and then used the syringe just below that to flush the cannula. About 20 seconds later, the patient suddenly looked very frightened and stopped breathing. It turned out that the syringe did not contain saline as expected, but contained rocuronium. This was again due to a communication breakdown between the registrar and another staff member. Simply, one person imagined the other person was doing something that was not the case. So it's very, very simple. Could you imagine ever giving a medication that you yourself had not drawn up? Well, it's unthinkable, isn't it? But we seem to do that from time to time. We do the unthinkable. So simple procedures are very important here. So if you draw something up, of course you can give it. If, however, somebody else has drawn it up and you haven't seen it being drawn up, worry. Don't give it, okay? And if it's not labelled, definitely don't give it. Another thing we seem to get quite often wrong at St George's is around the management of diabetes insipidus. Diabetes insipidus is a very dangerous condition because untreated within hours you become polyuric, hypernatremic, and then die. And in fact, this is exactly what happened with one case and has nearly happened with another case as well. The key is that, first of all, you have to recognise that pretty much everyone except endocrinologists are a little bit out of their depth with DI. The second thing you have to remember is that nil by mouth doesn't mean don't give important medication that keeps a patient alive, and this particularly applies to DI. The third thing you have to recognise is the ongoing deterioration of the patient. In fact, this patient became quite violent as he became increasingly dehydrated and realised what was going on, and the trick was to sedate him. This was, of course, not successful and a disastrous manoeuvre for this patient. So DI, very dangerous condition. Remember that the patient will need ongoing medication if they have DI, even if they're meant to be nil by mouth. The last thing I just encourage you to think about is about the fluctuations of your medical life. What I've got here is a little dashboard that one of my trainees put together that tried to express the times when he was more likely to do something silly than others. Because sometimes it's fairly easy because the workload's not that bad and the patients aren't very complicated to actually be very careful and do things properly. However, when we get tired, when we get very busy, when there are other challenges, then mistakes are much more likely to happen. And so I got a number of my trainees to try and put together a score that would tell you a little bit about whether you were likely to do something inadvertent. And you can do your own one. Here he's got us two dials, one relating to how new he is to the job. Another one relates to how many difficult patients there are under his care. One relates at the bottom to how refreshed he's feeling, and another one the degree of agency nurses on the ward. When you combine that with the number of outliers he might have and the fact that the consultant might be away, you can see that these things add up together to a potentially dangerous situation. So I'd encourage you to think a little bit about what your day is like, and instead of just kind of going on and doing your very best, think, well, perhaps today actually is a day when I need to be especially careful because my resources are a little bit below where I really like them to be, and the demands on my time are a little bit higher. So I hope that wasn't all doom and gloom. It's a fantastic place to work, St George's. So much going on, so many really interesting things, wonderful consultant body who are generally very, very supportive of your training and your learning. There are these messages and things that we have come across over many years and realise that these are key things to keep you out of trouble, and I hope learning about them today has been helpful for you. Thank you.